Well, baby, you've been on my mind. I think about you all the time. Oh, I want to see your face. That don't make me wait.
Welcome to Sleep Around the Podcast with Dr. Adam Matthew. I don't know why, but males who deal with heart conditions and have comorbidities along with sleep, it's through the roof. Mm-hmm. And I have strived in my career in sleep to work with that. And the first thing they look at me like I'm crazy. What are you doing in here with a dental appliance is what they call it. Not to toot my own horn, but I have successfully implemented programs into many different cardiologist areas all over the country because every single patient needs to be tested for sleep. We have these areas where I feel like they're small victories, right? And so today what I'd like to do is really talk about statistics stuff, but what does that really look like in a patient profile? And how can we be helpful? So I think that's a good way to start the podcast.
The things that we experience in a day can have very, very significant impacts on us. You also can experience that. You talk about the broken heart, and we always say like, a broken heart, you're not going to die from a broken heart. The unfortunate truth is there's actually a disorder, Takotsubo, where it is the broken heart disease.
Wow.
And so Takotsubo actually very frequently occurs in elderly patients when their significant other may pass away.
Oh my gosh.
And they literally die of a broken heart. The reason why is that we have this huge autonomic surge of these catecholamines. So basically your cell signalers that are creating this incredibly stressful response. It actually causes such a significant dynamic change. It changes the structure of your heart rapidly, and they die related to it. So it literally is called broken heart syndrome. And then the medical terminology is Takotsubo. And so when you talk, you always learn something with me.
I do,
It's like,
swear.
let's go.
Dan, did you know? He's like, Takotsubo, I'll have two.
No, you don't want any. We don't want any.
No.
But the reality is that what's fascinating when we talk about the heart, we can all relate to that. We've all had a broken heart, and we've all suffered through that and experienced the poor sleep and how it impacts every facet of our life. Our having sleep issues, does that impact our relationships? Does that impact our heart health? Does it impact us in other ways? And so the American Heart Association last year changed their mantra of life's simple 7 to life's essential 8. And the thing that they added was sleep. And so when you look at what the American Academy of Sleep Medicine and many times the mantras that I'm trying to get people to think about, it's duration, quality, timing of sleep, and then also what your quality of wakefulness is, right? So if you have any dysfunction in any of those, we need to start kind of dissecting that to see. We now know that things like sleep disorder breathing, yes, are relevant and increase your likelihood for those risk factors. But we also know that duration, if you're sleeping less than 6 hours of sleep, not only is your cardiovascular risk for increased morbidity and mortality exponentially increased, but also all-cause mortality. So for a variety of different reasons. There are over 70 different types of sleep disorders. Is it a one-size-fits-all? Do they all carry the same risk? What we now know, if you want to take it from the duration factor, we know that reduced total duration. That also is including those who are experiencing insomnia and having total sleep duration issues related to insomnia. That increases your cardiovascular risk. Those who have circadian rhythm disorders, namely thinking about things like shift work disorders, those who are working the third shift, that graveyard shift, those are, I've mentioned this before, World Health Organization identified it as an independent risk factor for as being a carcinogen, a cancer-causing agent, but it also associated with increased cardiovascular risk. You then think things like sleep disorder breathing, also increasing cardiovascular risk. You look at movement disorders in sleep. So something like restless leg syndrome, periodic limb movement disorder. We think that there may be a genetic relationship, but increases your risk for things like atrial fibrillation and cardiac dysrhythmias. Now you go into another category, one that is frequently overlooked, my area of expertise, my passion project, right? Central disorders of hypersomnolence. We look at what is the retrospective claims data. So we take health records from the insurance companies and we go, what are the patterns that we're seeing? But in addition, also being able to reflect on some of the things that we're looking in electronic health records and trying to see if are we seeing the same pattern. When we look at the retrospective claims data, there is a suggestion of if you have idiopathic hypersomnia or narcolepsy, you may be anywhere like 2 to 3 times the likelihood of those without those condition, being age matched, etc., to having adverse cardiovascular disease. Things like hypertension or high blood pressure, heart attack, heart failure, stroke, and a variety of other things that would be challenging for the heart, right? And so even if I wanted to take the journey on just talking about sleep disorder breathing and saying, okay, the snoring and all of that, and you even made that reflection, the person who you were with, and saying like, oh, well, they were having these drops in oxygen, and that's not good. That's unfortunately the biased mentality that many of us have focused on, is that it's the chronic intermittent hypoxia that has driven this increased risk. So the periods of my oxygen dropping, what we've learned is that's not the only factor that's contributing. We also see that the sleep fragmentation, the poor quality of sleep, is driving my nervous system to not acting normally and making my body function like it's at risk for dying.
Right. Fight or flight.
And that also drives this cardiovascular risk.
Okay.
And
gotcha.
so when we talk about sleep apnea, that's the main thing that we're talking about is
Again,
like
and I don't
measuring.
just want to do sleep apnea, but yeah.
Yeah, nope. But measuring that. But what we've learned is that if you were to do any other reason as to why a person is having fragmented sleep, that now causes a change in your autonomic nervous system, creating a higher sympathetic drive. What does that result in? That results in a dysregulation of your other hormones in your body, like your cortisol, leptin, ghrelin, a variety of different things, which now what that's going to do is that's going to make your heart, number one, pump faster. Okay.
Yeah, that's what I'm talking about.
But then in addition to that, it also is going to cause other downstream negative effects. What do I mean? So when I have my cortisol being elevated, and also a higher likelihood of insulin resistance. Insulin is the thing that makes my body use blood sugar appropriately. If I'm being resistant to insulin and my body's not using the blood sugar, what does that mean? My blood sugar levels are only going to go higher because they don't have anywhere else to go. So a precursor to diabetes.
I was going to say.
Leptin, ghrelin, what do? They are my hormones that are responsible for my food-seeking behaviors and my feeling of satiety or sense of fullness. They become dysregulated. I'm more hungry. I'm choosing less quality foods, and I don't feel full. So now I have created this milieu of things that are going to make me a heart attack haven, right? It's going to make me more likely to be sick in a variety of different ways. So you can take this and you can say, I have insomnia, I'm not sleeping well, I now have that insulin resistance. We've done it, we've seen these types of studies where they've taken young men who are volunteers, have no other medical issues. They've done 24-hour sleep deprivation. What do we see? Blood sugars start going through the roof, right? We now even see with a variety of different conditions that this is driving the development of things like type 2 diabetes. So again, just taking the concept that you can't separate day from night because it's a constant driver. And when we look at the statistics we're seeing in the United States, where we're only seeing increasing numbers of adults and children experiencing sleep disorders, and then we layer on other statistics that we're seeing, increased mental health issues, increased suicidal attempts and risk, increased obesity, overweight, increased cardiovascular disease. Basically, everything that we're seeing from a medical consequence, are we going, wow, this is a coincidence. This is such the grave coincidence of that when we look in the 1960s that we're now seeing the same rates of all of these diseases. And people were sleeping on average, an average adult sleeping 8.5 hours a night. And now we're seeing that people are barely sleeping 6.8 hours a night. Is it a coincidence? Is it just increased awareness, increased screening? I would like to say that our body likes to function as it was designed. And so when we're operating it differently, we're going to definitely see different outcomes.
The rate of obesity is what percentage now?
So now what we're seeing is that 75% of adults are considered overweight to obese.
Okay. And what is that? What does that mean to our listeners?
So 3 out of 4 people
3 out of 4 have a body mass index
are overweight or obese.
Okay.
And so meaning that their body mass index is at least greater than 25, right?
Wow.
And so as we're seeing that the weight is increasing, there is that potential risk that may be increasing your risk for other medical comorbidity. Now, I always like to give the disclaimer that it's not a one size fits all, right? So someone sees that my BMI is 30,
right,
and people become offended, which appropriately so. Don't just judge me because of what my weight is and now just say, like, discount me as that this is the reason. We do see that there is definitely genetic protective factors. So someone could have the same exact BMI, they're not gonna have sleep apnea, they're not gonna have high blood pressure, not gonna have...
It reminds me when I was a kid, they had that chart that said if you're 6'2", you need to weigh 175 pounds.
Mm-hmm.
There's no way I was going to do that.
Sure.
So, but those were just predictors, right?
Sure.
The same way, but in a real world sense.
Sure. At the end of the day, BMI is not the end all be all in saying what someone's health is, right?
100%.
And so there's a variety of ways for us to look at overweight and obesity. And we also recognize that even how your weight is distributed has a very, very significant component, right? So do you have more central adiposity, meaning that does your weight become more located in kind of the abdominal region? Do you have more visceral fat, meaning that you're just like a big stocky person, but I did imaging on you and I see there's a lot of fat adipose tissue that's surrounding your organs. These different factors also can contribute. But I would say the take home point is that we're always looking at what is body weight optimization for the person in front of me. But we're seeing that this risk of having weight issues is growing. Again, I can't ignore this is a growing statistic as we're seeing the growing number of people who are having sleep issues. And so even when we look historically of that, we initially were focusing on the adults with sleep issues, and we're seeing this adult trend, 75% of adults being overweight to obese, 50% of those adults saying in the last year, I have had attempts at weight loss, right? So at least 50% of those people saying, this isn't who I want to be. This isn't who I want to be. I'm recognizing it's a problem. It's not, I don't feel great. But now we're even seeing those statistics affecting our kids. 1/3, 1 in 3 children and adolescents are considered overweight or obese. And the challenge with that statistic is that we know based on research, that statistic is predicted as early as in the first 6 months of life. So a baby who is in the first 6 months of life,
which all they usually eat is formula or breast milk.
Yep.
Okay.
Is that if we see that they're starting to track in a much higher, even an overweight growth trajectory, that the prediction of them staying in that becomes almost like their own self-fulfilling prophecy. Now, again, it's not saying you should starve a baby and don't feed them. Please don't believe that at all. But it also is starting to introduce some of these concepts that there are likely genetic predispositions, right? There are some things that are out of our control. However, increasing our awareness of what is the things that we can control, what are the things that we need to be mindful of, and then do we have different frameworks of how we're providing the right preventative care?
Those statistics that you gave, that 75%, where does that lie in between men and women, male, female? Because I know BMI is different.
Sure.
A woman's BMI is normally higher because she's a woman, meaning
we have breast tissue. We have areas in the abdominal region where we are more likely to collect adipose Y because we have no bony structures that are protecting our uterus, right? And so the fat tissue there is what actually is protecting the uterus. And so if you were to become pregnant, that obviously would be an additional barrier or layer. And so we do have different kind of distributions of fat.
Different.
Now, when you're looking at what are the risk factors for the development of overweight or obesity, I think that you can see different rates of obesity based on gender, based on race, and even based on locale.
Wow.
And so it's not...
So like the South would be different than the Northeast.
Exactly. So it's not a one-size-fits-all of saying like, you're a white guy and you're this age, your statistic is this. It's like, you're a white guy, you're this age, you're in this state.
You live in Mississippi.
Exactly. And again, that's going back to even where you talk about what is the global approach right now, where everyone's everyone's using these really buzzwords, in vogue, social determinants of health. We're talking about there being equity and inclusion and diversity. And the reality is I say those things in almost a callous way. You can see that I purposely am like dismissive of it. It's not because I'm dismissive of those being really important things.
Right.
It's because many times the approach in medicine is one that I feel is further stigmatizing these different groups and these different areas and applying frameworks that actually are creating more barriers to care and improvement in outcomes than they're solving. So what I would say is that when we look at these statistics and we say you're from this certain state and you're this age and you're this gender and you're this race, it helps us just to understand where there's differences. It hasn't given us any information now of causation or resolution.
The goal of mine in working for the last almost 3 years on this is to have a patient pathway where I bring in a cardiologist.
Cardiologist, I have a sleep doctor, I have you name the specialist.
Right.
To me as the patient, I'm going, fuck, how many doctors do I have to see? How many days off from work do I have to take? What is this? And now I'm prioritizing going, well, I only have this many days off from work. Do I need to, I'm going to use it for the heart. I definitely am going to use it for the heart because my heart has to work, right? For me to survive, right? And so one of the things that we really do need to think about when we're saying that everything, we need to just totally break the system and rebuild it, is really rebuilding it in the form of through the patient lens, the patient journey, and making it easy for them. We're creating so many barriers. And so where we're at right now is that I even have fear, right? I even have fear, even though this sounds counterintuitive, of making the cardiologist so aware of sleep apnea without them being aware first of how important just sleep by itself is.
True.
Why? Because we know if you're a person who has sleep apnea, it's extraordinarily high likelihood that that's not the only sleep disorder you have.
I agree.
Most patients who have sleep apnea also have a circadian rhythm disorder. They have bruxism, they have restless leg, periodic limb movement disorder, behavior disorder, excessive daytime sleeping. Like you name the other sleep
Depression,
disorder,
anxiety,
they have it. 100%. So I had done a study at Geisinger where we had done surveys for adult patients who have congenital heart disease. Congenital heart disease, they are high risk for congestive heart failure. In fact, people who have congenital heart disease, I've learned this from a very close friend of mine, Dr. Chris Derby. He's an incredible adult and pediatric congenital heart surgeon. And so he had shared with me some of the cardiology literature, which that individuals who are born with congenital heart disease, even simple congenital heart disease, they're 13 times higher risk for acquired heart disease. That's your high blood pressure, your heart attacks, your congestive heart failure. 85% had features of a sleep disorder. Right.
Wow.
And then when we broke it down of what features of a sleep disorder, those who had one sleep disorder, about 70% of them had features of more than one. So if you had one,
then you
had more than one. If I'm a person who have obstructive sleep apnea, you give me a CPAP to fit my obstructive sleep apnea, but you don't address my insomnia. And now I'm laying in bed for an hour with this thing on my face. That now all I'm doing is focusing on this thing on my face. There's no way in hell I'm falling asleep. And I don't care if you replace that same thing with a dental device. I'm going,
nope, I agree.
Yeah. We have to really move in a direction of disentangling the fact that sleep and wake, number one, we shouldn't be viewing as separate. This is a part of your cardiovascular health. Celebrities, you see them one day, they're 250 pounds, the next day they're 100 pounds. And you're like, what the heck happened?
Crazy.
You see their face become really thin and
take it off of celebrities. I have friends.
Yeah. Yeah. And so essentially what you're seeing, they first will develop the weight loss interface. It's something called lipodystrophy, right? And so for me, medically, when I see lipodystrophy, I first always think about genetic disorders because there's specific disorders that cause that. But it's because that's the area that we tend to see weight loss first. What ends up happening is that this is just interfering with the normal chemical cascades that occur in your body in terms of how you utilize energies and how you're going to be likely to gain weight and maintain a high weight. We see that people are dropping weight. The goal of that is purely, the first is always saying, if I lose weight, I decrease my risk for diabetes.
Yes.
And in fact, that's one of the things. We need to see that there's insulin resistance or features of type 2 diabetes in order to even get those medications. The thing that we're missing in this type of area and landscape is actually doing, again, a measure of not just day, right? We are looking at what are your food seeking behaviors? Are you having full? Are you feeling full? What is your weight? These are all the daytime things. We're not looking at, are you sleeping better? Are you snoring? Did you have sleep apnea? You no longer have sleep apnea. The reason why I think that these things are important is because they have already proven to be critical in other areas, right? So you take the obesity journey, right? This is a hard one. We've already said 75%, right? So the likelihood is if you are watching this or listening to this right now, you have a very high likelihood of falling in that statistic, just based on statistics. Not that I'm calling anyone out to say that you have a weight issue. Statistically speaking, you are likely the 3 of 4 people, right? Who are on this weight loss journey. It's not a you could, you should, we hope. You must have a sleep evaluation. A sleep test. Why? Because the majority have things like obstructive sleep apnea. And it's not a nicety to know. It is, if I don't know that, and I subject you to the surgery, your risk for morbidity and mortality.
Dying during surgery.
Dying. Is going to be very, very high. And so now this has changed the dynamics in terms of things that we do, like anesthesia pre-op, even outside of bariatric surgery. We look, I will tell you, I've been associated with healthcare systems where the patient in a PACU recovering did not know that they either were on a CPAP at home or had undiagnosed sleep apnea, died. Died. And so these are real things to be worried about because it's not a nicety to have good sleep. It is not shameful to say, I have snoring or I don't feel well rested or I'm getting away with 5 hours of sleep. The reality is that we are seeing healthcare changing in a way where sleep is an indisputable factor that contributes to your overall wellness.
I would love to be able to teach these cardiologists and these board members. I know that teaching them the importance of all of sleep is value.
100%.
You have truly changed my perspective. Instead of just focusing on OSA, I'm able to bring in other things.
What you're trying to create is a new framework, right? And so for me to think that I am going to retrain a cardiologist or endocrinologist or even a neurologist saying like, this is what you need to do. The reality is that at this point, healthcare is still viewed as being a business. And we have so many things that we need to do in a day in order to sustain the business. And so when you're asking someone to do more without understanding how it benefits them as a physician, but even more importantly, the thing that they're treating, you're going to be met with nothing but resistance.
And I'm actually playing conversations.
Yeah, like you have like 10 heads.
That's not my job.
That's not my job. 100%.
I've had them tell me that already.
100%.
You know what? That's why we have you, and then you tell us where to send the referrals to for good. You know, there's best sleep doctors.
So
again,
the reality is,
that's why I looked at you kind of crazy when you were talking to her. I was like, I mean, you're right. And I would love to. But I only get a certain amount of time.
And so this is where I think that as we're gaining more understanding of different areas of medicine and how sleep plays a role, it becomes really important to utilize that, right? And so in medicine, we're always saying we want to use evidence-based medicine, which means that we have research to back up what we're doing in order to change the practices that we have or implement practices that we have, right? So we wanted to understand what are some of the factors that are driving the risks and And you know that there's always this debate of like, does CPAP make a difference? Does treating it make a difference, et cetera? And what we have from that study is that there were 5 very specific proteins that actually are exquisitely involved in the coagulation pathway. So that's your blood clotting pathway.
Yeah.
Not good when it's being done inappropriately, right? That is your risk factor for stroke, heart attack, all bad things to come. And so what we had identified is that we saw in those who had untreated obstructive sleep apnea this very high production profile. And after the initiation, we saw a mitigation of that,
Really?
right? And so when you start talking the language, I'm not talking about sleep anymore.
Right.
I'm talking about your cardiology.
Yeah.
You care about how things clot, right? As a cardiologist, I'm not talking about sleep. I'm talking about something that's going to totally impact the likelihood of your patient dying from a myocardial infarction, right? Something that's going to totally impact your patient who has atrial fibrillation developing a clot that blows off and causes stroke. And so the reality is that the failure of the cardiologist to recognize these things is not the failure of the cardiologist. It's the failure of us in the sleep field not communicating appropriately to the other disciplines and to our patients who we serve, who are our guiding light of what we do, why this is relevant, why this fits into their treatment and consideration profiles. Because when we don't do that, of course, we're all going, I have too much to do. I have too much to do. That's on the next. I mean, we had a whole segment about time management, right? And we said, create that Punnett square of urgent, non-urgent, high priority, low priority. If you're coming to me about sleep and you're going, it's this thing that could potentially I'm going, you fall into the low priority, not urgent. At some point along this treatment paradigm, it would be a nicety for you to see someone to make you feel good, right? And the reality is it's not a nicety. It's not to make you feel good. It's to freaking preserve your life and make you have the optimal life so you're not suffering with having to take more drugs and having to see more specialists, but actually to have a good full 24 hours. And this is one of the things. I'm going to give a huge props to Katie Cedarberg. So she is a postdoc. So she's still in her ongoing study under Emmanuel Mignot at Stanford. This young woman is brilliant. She is so brilliant. We've now have multiple publications together, multiple abstracts, posters. She is our future of where sleep medicine is going because she is taking the dynamics of how sleep impact the outcomes. We have another study that's looking at periodic limb movement disorder. So that's how I look at a sleep study, see how frequently you're moving your legs, and we're looking at similar profiles. What does that proteomic profile look like? The reason these things are important is because when I go and I talk to someone, a neurologist, an endocrinologist, a cardiologist, a generalist, and I'm like, yeah, they have increased leg movements. I go, okay. That's nice. I don't know what to do with that. Why should I care?
Why is that important?
Why should I care? Why should I care? How does that impact me? That's a you job. You're the sleep doctor. Why should I care? And so the reality is the reason why you should care is because if you're a person who has developing chronic kidney issues, you're going to be more likely to progress to end-stage renal disease because of these untreated sleep disorders, because it's going to drive a deconditioning of your heart. In fact, it's bidirectional. The worse your kidneys get, the more I'm going to see these periodic movements, restless leg syndrome, et cetera. And so instead of us again saying, I'm looking at my primary disease state and I'm focusing on my primary disease state, and for some reason we continue to be trained of saying we only can quantify and qualify the impacts of that based on what we're doing during the day, it makes no sense. It makes no sense. It's like saying I only see the world through my left eye. My right eye doesn't work anymore.
Jeez. So this whole time I'm thinking Wizard of Oz, right? And it occurred to me, that the Tin Man was a heart, right? That the Scarecrow was a brain. And the lion was courage. Where do we find courage?
So I think the courage that we need to have is having a podcast like this,
There you
right?
go.
Is that we are willing to say and stand on a line, right?
I will follow you, Ann, to wherever. I will run through a brick wall for you.
Well, hopefully I don't need you running through any brick walls. But the reality is the courage is saying that I'm calling out my fellow providers and saying, stop being stupid. Right. And I'm not saying this in an insulting capacity. I'm saying, in what world does it make sense to put blinders on and limit us in terms of evaluating information that's available to better treat the individual who's in front of you? The second thing I would say is it takes courage for people who feel shamed and insecure for discussing their sleep, especially when they get negatively reinforced. Sleep more, sleep hygiene. That's not a problem. Everyone has that problem, right? Have the courage to say, no, I'm going to take something like this journal or whatever else to be able to characterize what I'm experiencing, to demand better days ahead.
You know, you said some things that I hope resonate with our listeners and viewers, because it resonated with me. I thought when we were talking about heart health, we were just directly going into the statistics and stuff that we have learned today. That's interesting you talk about that. I know that heartache happens in many forms, whether you said have a crush and you break up, but also death, right? And then when you gave me this statistic, now what did you call it again? This is amazing.
The Takotsubo broken heart syndrome.
So I thought about where the red fern grows, and I always thought that was kind of a thing that, if everybody's not familiar, it's an amazing book, unbelievable movie too. But when a loved one passes, very shortly after, there's a period of time. I had no idea it was from a broken heart.
And many of us feel insecure for acknowledging that as well, right?
Yeah.
I mean, we think it's all in our head.
Right.
But the reality is that there's not a function in our body that does not have a feedback mechanism that affects every other organ system, right?
Again, this is, I say this almost every podcast now, but you continue to blow me away. Dr. Ann, thank you so much.
Thank you.
Thank you all for sleeping around with Dr. Ann and Matthew.
Yep, we're just keeping it B2C, friends.
Thank you.